Assalamu alaikum. Let's talk about immunodeficiency disorders. In immunodeficiency disorders, there are phagocyte deficiency, there are B cell deficiency, there are T cell deficiency, and there is B and T cell deficiency. Start with this phagocyte dysfunction. In phagocyte dysfunction, there are three disorders: leukocyte adhesion deficiency, LAD, leukocyte adhesion deficiency, Shediac-Higashi syndrome, and chronic granulomatous disease. In leukocyte adhesion deficiency type 1, it is autosomal recessive, so AR autosomal recessive, and in here defect in LFA integrin, which is CD18 protein on phagocytes that leads to main words are impaired migration and chemotaxis. And we know that the chemotactic substances are C5a, LTB4, IL-8, and some bacterial products. So, impaired migration and chemotaxis by these components. So, that is leukocyte adhesion deficiency, which is an autosomal recessive and a defect in CD18 protein. And in leukocyte adhesion deficiency in LAD, what happens in the LAD? There is lead separation more than 30 days of the umbilical cord, as there is no migration of this product, chemotactic substance. So there is absent pus formation. What does pus means? Pus means dead neutrophil, as it does not migrate, so there is absent pus and dysfunctional neutrophil. That's why there is recurrent skin and mucosal bacterial infections. So what we will found, there is increased neutrophil in the blood and absence of neutrophil at the infection site. So increased neutrophil at the blood, absence of neutrophil at infection site, absence of neutrophil at the infection site, which will impair the healing, which will impair the healing. That is leukocyte adhesion deficiency type 1. Okay, so if you look at this box, leukocyte adhesion disorder, again defect in CD18 containing integrins and impaired leukocyte adhesion and endothelial transmigration. There is skin and mucosal infection, there is skin and mucosal infection, cellulitis, there may be periodontitis, but without pus, main word, without pus. Impaired wound healing, there is impaired wound healing and delayed separation of the umbilical cord more than 3 weeks. If we do CBC, there is leukocytosis and neutrophilia. There is leukocytosis and there is leukophilia. If we do blood culture, BC blood culture, infection most commonly caused by Staph aureus, and some gram-negative bacilli Biopsy shows inflammatory infiltrate but without neutrophil. The diagnosis in here, diagnosis is confirmed by flow cytometry. What we'll found here, there is deficient CD18 expression on the surface of the leukocytes. Okay, now the next, Shediac-Higashi syndrome. what happens in the, it's a rare autosomal recessive disorder. It is also autosomal recessive, AR autosomal recessive. And in here there is impaired lysosomal trafficking, defect in lysosomal trafficking regulator gene, LYST, lysosomal trafficking regulator gene, microtubule dysfunction in phagosome, lysosomal dysfunction. There is microtubule dysfunction in phagosome lysosome fusion. In Shediac Higashi, think about the plain road, progressive neurodegeneration, lymphohistiocytosis. There is oculocutaneous albinism, very classic. Oculocutaneous albinism. There is recurrent pyogenic infection, and there is peripheral neuropathy. There is peripheral neuropathy. So in Shediac Higashi syndrome, if you look at the clinical presentation, there is immunodeficiency, and most importantly, there is oculocutaneous albinism, and bleeding can develop due to lack of platelet dense granule to initiate formation of the platelet plaque. And there is a rarely patient may present with accelerated phases of Shediac Higashi syndrome with the signs of lymphophagocytic histiocytosis, lymphohistiocytic infiltration of all organ, and excessive macrophage activation. These hemophagocytic lymphohistiocytes causes excessive macrophage activation, causes fever, splenomegaly, cytopenia, anemia, thrombocytopenia, hepatitis, and encephalopathy. uh, it- we will found giant granules. This is the giant granule in granulocyte and platelet, giant granule in the granulocyte and the platelet, and mild coagulation defect. It is diagnosed by the peripheral blood film, where there is presence of giant cytoplasmic granule in the neutrophil, and we can do the genetic testing performed to confirm the diagnostic. Genetic testing can also identify CHS1LYST mutation. Okay, now I would like to discuss the chronic granulomatous disease. Chronic granulomatous disease, defect in NADPH oxidase. It's a rare primary immunodeficiency disease, disorder of the phagocyte metabolism characterized by phagocytes with impaired NADPH oxidase. There is a defect in NADPH oxidase. So there is decreased reactive oxygen species, decreased superoxide, decreased respiratory burst in neutrophil. It is X-linked. So first two is autosomal recessive in phagocyte dysfunction, leukocyte adhesion deficiency, lead, Shediac Higashi syndrome. Both are autosomal recessive, but CGD is X-linked. It is X-linked. Increase in here, increase susceptibility of the catalase positive organism. Uh, Catalase positive organism like Granny's cat, kid, are positive. Like, what are the organism? A catalase positive organism: Staph aureus, Burkholderia, Serratia, Nocardia. There may be Aspergillus fumigatus. Aspergillus fumigatus. There are clinical presentation like severe bacterial and fungal infection with catalase positive organism. On lung, there may be pneumonia. In skin, there may be cellulitis, suppuration, Suppurative adenitis may be found in the lymph node, and in the liver there may be abscess. Patient often develop granuloma in the GIT and genitourinary tract due to chronic activation of the inflammatory cytokine. How we can diagnose? We can diagnose via DHR flow cytometry, dihydrorotamine flow cytometry. It detects, what does dihydrofluororotamine? It detects the generation of oxygen free radical by measuring the oxidation of DHR to rhodamine. So it detects the oxidation of dihydrorhodamine to rhodamine, a fluorescent green compound that can be detected on flow cytometry. Fluorescent green compound that can be detected on flow. These, there is reduced or absent fluorescence. There is reduced or absence fluorescence on CGD. So there is reduced or absent fluorescence on CGD. So there is decreased green fluorescence. So there is decreased green fluorescence. And we can do another test, NBT, nitroblue tetrazolium test. It is less sensitive than dihydrorhodamine flow cytometry. In the presence of NBT, functional neutrophil produce reactive oxygen species, thereby converting the pale, it converts the pale nitro blue tetrazolium to dark blue, dark dark blue formation that precipitates within the cell. There is no change in color in patients with CGD. So normally nitro blue tetrazolium, what does this dye actually does? It converts the pale blue nitro blue tetrazolium to dark blue formation that may precipitate within the cell. If there is chronic granulomatous disease, there is no change in the color. So the most important word in NBT, their NBT fails to change the color into blue. Normally these nitro blue becomes a dark blue and forms formation. It fails to turn blue in CGD, an abnormal dihydrorhodamine test, which is a classic, which is important, sensitive, and it fails. Uh, it decrease. There is reduced or absent fluorescence in patients. There is reduced and absent fluorescence in patients with CGD. So these are the chronic granulomatous disease. Look here, in chronic granulomatous disease, it is X-linked recessive mutation, X-linked recessive mutation of the NADPH oxidase. There is impaired respiratory burst and decreased reactive oxygen species, inhibition of the phagocytic intracellular killing. There is recurrent bacterial and fungal infection with catalase positive organism. Lungs, in lungs can cause pneumonia, skin can cause cellulitis, and lymph node suppurative adenitis, lymphadenitis, diffuse granuloma, gastrointestinal and genitourinary dihydroflow, measurement of the neutrophil superoxide production, measurement of neutrophil superoxide production by dihydrorhodamine flow cytometry, which is preferred, and nitroblue tetrazolium test can be done. As a treatment, TMP, SMX, itraconazole, and interferon gamma can be given. Active infection culture based antimicrobial therapy should be given, and hematopoietic cell transplant is curative. And catalase positive organisms are Staph aureus, Burkholderia, Capacia, Serratia marcescens, Nocardia, and Aspergillus. and Aspergillus. Okay, now B and T cell disorder. B and T cell disorder can be remembered by Shaw. That means severe combined immunodeficiency, hyper IgM syndrome, ataxia telangiectasia, and Wiskott-Aldrich syndrome. Severe combined immunodeficiency disease. In severe combined immunodeficiency disease, in SCID, what happens in SCID? There is several types. It is several types, including defective interleukin 2R gamma chain. Defective interleukin 2R gamma chain. It is most common, and it may be X-linked. It is the X-linked recessive and adenosine deaminase deficiency. It is autosomal recessive. So in SCID there may be autosomal recessive, which is ADA deficiency, and interleukin 2 are gamma chain defective, which is X-linked recessive, and there is RAG mutation VDJ recombination defect, failure to thrive, chronic diarrhea, thrush, recurrent bacterial, viral, fungal, and protozoal infection. There may be recurrent bacterial, viral, fungal, and protozoal. So X-linked one is interleukin 2RG gene mutation, and adenosine deaminase. ADA deficiency is autosomal recessive. Now, in SCID, severe combined immunodeficiency disease, there is uh, decreased T cell receptor excision circle track, decreased track, part of newborn screening for SCID. There is absent thymic shadow, germinal centers, and T cell. There is absent thymic shadow. On chest X-ray, there is absence of germinal center on found in lymph node biopsy, and there is absence of T cell found in flow cytometry. In ataxia telangiectasia means defect in ATM gene, failure to detect DNA damage. It fails to detect, failure to detect DNA damage, failure to halt progression of cell cycle, failure to halt progression of cell cycle. There is mutation accumulation, and it is also autosomal recessive. So ataxia telangiectasia, it is also autosomal recessive, and in here there is defect in ATM genes, and it fails to detect the DNA damage. It fails to detect the DNA damage. In ataxia telangiectasia, there is ataxia, there is angioma, spider angioma, there is IgA deficiency, increased sensitivity to radiation, limit X-ray exposure, increase alpha fetoprotein, decrease age, lymphopenia, and cerebellar atrophy, increase risk of leukemia and lymphoma. There is next is hyper IgM syndrome, most commonly due to defective CD40 ligand on T helper CD40 ligand on T helper cell. There is class switching defect, and it is also X-linked recessive. There is severe pyogenic infection early in life, opportunistic infection with pneumocystis, site cryptosporidium, and CMV. In hyper IgM, IgM is high, decreased age, failure to make the germinal center. And finally, the Wiskott-Aldrich syndrome. Wiskott-Aldrich is Mr. X mutation in the WAS gene, and there is leukocytes and platelet are unable to recognize the actin cytoskeleton. So defective antigen presentation. So Wiskott-Aldrich causes defective antigen presentation. And ataxia telangiectasia defect in ATM gene, and it detect the DNA damage. It failed to detect the DNA damage. And Wiskott-Aldrich mutation in the WAS gene, recurrent infection, thrombocytopenia, eczema, X-linked, and tumor increased risk of autoimmune malignancy. In here, in Wiskott Aldrich, decrease IgG and decrease to normal IgG or IgM and increase IgE and A, fewer and smaller platelets. So that's all about phagocyte dysfunction and B and T cell disorder. Hope you enjoy.